And welcome to the 6th Annual Dartmouth Symposium on Healthcare Delivery Science. I'm Molly Castaldo. I'm the Assistant Director of Alumni Engagement at the MHCDS program. I'm so excited to see you here. I'm a little too excited, I think, because I'm having a having a hard time with my adrenaline. But anyway, I want to say how pleased the alumni volunteers who helped to plan this event and the MHCDS staff are that you've joined us today to talk about healthcare equity, because it's a really important topic. It's a complicated topic. It's also a broad topic, and we've been planning it, how to organize the discussion since last year's symposium. Actually, the conception for the idea to talk about health equity arose during a dinner discussion at last year's symposium. And the alumni volunteers and I have wrestled with the questions like, how do we deliver more equitable care? Can we really create more health equity? And what insights can healthcare delivery science add to this equation? So we're excited with the result in this program, and using our healthcare delivery science lens, we'll be discussing the practical how-to aspects of designing and implementing sustainable initiatives to promote health equity. And we'll also be incorporating stories and opportunities for reflection and questioning assumption. To give you a mental picture of where we're going in the organization of the program, we're going to start at a macro level, thinking about whether we can or should try to move the needle, and delving deeper, we'll explore the delivery science aspect of that, like how do we have an impact with limited resources, what is the business case for investing in social determinants of health, how can we build and sustain the necessary partnerships, influence policy, etc. For the second half of the day tomorrow, we'll narrow the focus a bit and consider the application of these principles to promote equity within specific populations or people with particular challenges. So we're also going to dedicate time this afternoon. We have a workshop this afternoon and also a session with some stories that reflect on bias, racial and otherwise, and the impact that it has on patients, providers, and healthcare delivery. So a few housekeeping items before we begin. We have assigned seats for this afternoon's workshop and tomorrow's morning session on innovation. These sessions involve table-based discussions, and we found that if we switch seats around and you sit with different people, it allows for sort of more robust conversation, and it helps you to meet new people and build your network and your friendships. So thank you in advance for your participation in that aspect of the programming. We also will have microphones at either side of the stage located there throughout the program. So during question and answer times, we'll invite you to approach the microphone if you have a question or comment that you'd like to make. We do look forward to hearing from a variety of perspectives and there are a lot of people in the room. If you happen to be one of those people who always has a ton of questions, that's wonderful. We want to hear your questions, but we also appreciate if sometimes you might hold back and see if others have questions and listen. So the more practical housekeeping items, we'll have breaks after every long session, 30 minutes, and the exits are at the rear of the room. Bathrooms are out the rear exits and on your left, and there is a charging station for electronics over there on the right side of the room, if you need that. We will have continuing education credit available. You'll get an email link after the event that will tell you how to access your credit. And I need to run through the disclosures as part of that process. Finally, the presentations, all of the presentations over the next 2 days will be recorded. We'll share proceedings with you after the event, so you'll have an opportunity to be able to review the videos and some summary notes. We'll send you an email with those after the event. And I just want to thank Beth Perkins while I'm up here, because without her, yes. Yeah, without her organizing help and everything, she thinks of everything, and she knows everybody, and she even arranged good weather. So, yeah, go Beth. With that, I'm going to turn it over to Kirsten and Samila.
Good morning. It's very curious for someone like me to come here and feel like I'm going home. This life is full of unpredictable things. So thank you so much for tolerating me longitudinally, mysteriously. So, and it's a thrill. Just a couple of reflections on equity. As I introduce Samila, does anyone who works in healthcare have patient partners or patient and family advisory council? If you just raise your hands if you do. Great, okay, good. So I think one of the most important prerequisites to equity is actually making sure that you can hear all of the voices in the room. And one of the big principles of equity itself is actually that you then have to amplify the softest voices. And one of the tragedy, I think, of my career, and I didn't have anyone in medicine before I became a family doc, so I didn't realize this was going to happen. The tragedy that I encountered in clinical care was actually the softest voice in the room is often the patient's voice. And that was surprising to me. I actually kind of thought, remember that show, Dr. Quinn, Medicine Woman, where she was like running around taking people's appendixes out on the kitchen table, and right? Like that was my role model, because I just didn't have anyone medical in my family, and I thought that was a great idea. Didn't quite turn out like that because I practice in Somerville, Massachusetts, but you know, kitchen tables still matter, just not for Abbeys. And so that was sort of I realized in reflecting, once I was a fully formed doctor person, that actually part of that paradigm was very much the sort of solo hero, even if she happened to be female and riding a horse. And I was now, female not riding a horse and still feeling very alone. One of the most wonderful ways to avoid that is actually to really work hard to equalize the relationship when you're in the room and when you are in the boardroom in healthcare with the people that we serve. And so we embarked on joining with patients at almost every level of care that we can. And Samila and I get to work together at our clinic. We both spend a lot of time at Union Square Family Health Center. I get paid for it, she doesn't. And so we got to know each other, and she is one of our patient partners. We intentionally rotate folks because it's exhausting to ask her to volunteer her time for more than about 2 years. It's wonderful to have fresh eyes on healthcare because it's really important, I think, to see the peeling paint on the windowsills that you just won't see when you've lived in the house for 20 years. And that is a gift that we're always aware of. And one of the most exciting things about Samila is that she's not in an official capacity the way you would with a PFAC, right, a Patient and Family Advisory Council. So she really can just come into an interaction with us and just give exactly what she thinks, and we thank her profusely, and and then try and improve the care, and then have to ask her how it went. I don't know how the scripting went, actually. I forgot to ask you that. You'll have to tell us. So I want to just introduce her to you. She and I have known each other quite a long time, right? I think
13 years.
Yeah, 13 years. I'm getting old. And so she very graciously agreed to come and tell a little bit about her experience in healthcare, which has been quite a journey to different countries and multiple health systems. Fortunately, it has a happy ending, which is always great. Try to give that away. But I just want to welcome her. Samila Miranda is going to now talk to us.
Thank you. Thank you. Good morning. My name is Samila. I'm originally from Brazil. I'm here for almost 15 years, and I was invited by her to share a little bit about public health system here and compared to Brazil. So I'm from Minas Gerais. It's on the southeast of Brazil. I'm from a tiny city who was known for the paraglider championship, and and we have the delicious pão de queijo, which is called cheese bread. So when I first came here, I was very impressed with the generosity of people. I didn't speak English, So sometimes it was hard to me to communicate. So, and when I find CAJ, I was very relieved because I have people who speak my language. So I could be seen by a doctor who understand me on everything I could say. And in the other hand, in Brazil, if you are an immigrant, it's very hard to find people who can translate for you. And was very good. And being treated by a public system here, I can say that it's wonderful. Because just to give you guys an idea, in Brazil, if you need to be seen by a specialist, and if you don't have a very good health insurance, if you don't have money, if you don't have a premium health insurance, you need to go to a certain place, and they're gonna give you a piece of paper with a stamp and a signature of that specific doctor, and they have only a few spots. And you need to go early in the morning sometimes, maybe around 4 or 5 a.m. And if you don't go, you cannot be seen by the doctor. If you don't have money to pay, they're not going to be seeing you. So in here, it's completely different. I am taken care by the public health system, and I have everything I need. I would never imagine if I was in Brazil, and I would never have the same as I have here. I can give you guys an experience of myself. I have 2 kids, and when I was pregnant from my first kid, he was diagnosed with a heart condition when I was pregnant at 18 weeks. So I had all the support that I need. I think when I was 30 weeks of pregnancy, they transferred me to a best hospital so they can give me all the support for me and for the baby. So I cannot thank enough to the CAJ, to the USA to give me that support. So if I can compare in Brazil, I think if that happens to me, I would have the support too, but this is gonna take so long. Maybe I couldn't have the same support that I have here. Maybe if I don't have the money to pay for do so many ultrasounds like I did here, I don't know what is gonna happen to me and to my baby. So, yeah, I'm very glad to be treated here by a public health system, and I hope in Brazil, so they could improve. They have a very good system that is called SUS. It's SUS, so it's all free. They have the money, but because of the corruption, this money never gets to the people that most need. So, and I think they are trying to improve, they are trying to change, but they have a long way to go. They have so many doctors, they have so many clinics. Sometimes those clinics have all the support they need, but they cannot have the patients because they don't have money to maintain the clinic. And yeah, it's very sad to say that they have the best. I can compare from here in Brazil with the clinics, but because of the corruption, the things didn't work. And do you want me to add anything?
So Samila and I were talking about this, and I think it's really important to her that it not come off as feeling like Brazil is all bad and we're all good. I think she's interacted with a very unusual healthcare system. Massachusetts has universal health care. That is not true in the United States everywhere, and you know that, but we asked you to speak about your experience. I looked up just a few, I work a lot in Brazil actually, and because I got to know the culture from my patients, and the United States spends about 20 times more of its GDP than Brazil does, which is an interesting fact. And the vaccination rates for children in Brazil are about 10 points better across the board. So I think there's very much a decision about where one puts one's resources. Corruption is absolutely an issue there. It's actually an issue here that we tend not to look at as clearly. Just saying. And yeah, more recently. I think another challenge I think that that international work raises for us is trying to figure out the best of all of the healthcare systems across the world. And I effortlessly get to do this because I have all of these different cultures that I encounter in my office. And that's a wonderful thing. So we wanted to share a little piece of that. How do we in the United States get our vaccination rates up to the level of Brazil? How does Brazil learn from how to give really good care coordination and integration across their systems? Because they do have all of the important parts that Samila would have needed if she had had Lucas when she was in Brazil. So we just wanted to start with unanswerable questions because, hey, how fun is that? And say thank you for listening for this morning. She'll be around all day. You can ask her questions.
Thank you.